For patients in whom curative surgery is not an option, we do think about using systemic therapies. These might be patients who either have metastatic disease at the time of diagnosis, perhaps they're patients who have an unresectable primary tumor, just given the location of the primary tumor, or perhaps they're patients for whom their other medical comorbidities prevent or make a surgery unsafe. And so we have that same list of systemic therapy options, and maybe I'll group them into categories. So there are somatostatin analogs that include octreotide and lanreotide. Again, these do not shrink tumors, but will yield tumor control. We have biologic therapies that include targeted agents like tyrosine kinase inhibitors, like sunitinib, or mTOR inhibitors like everolimus. These also do not tend to shrink the tumor, but yield tumor control or stability as a best response. We also have chemotherapies. So temozolomide and capecitabine are often used for metastatic pancreatic NETs. We're actually also sometimes considering using these pre-operatively. So if a surgeon says to me, hey, I really need a little bit of tumor shrinkage before considering a surgery for this patient, it might make the surgery easier. We will consider that for pancreatic NETs. And then lastly is the use of PRRT, or peptide receptor radionuclide therapy with lutetium-177 dotatate. And this is also indicated and approved for patients with metastatic NETs. There are some ongoing clinical trials evaluating the use of PRRT perioperatively, also in an effort to see, does it help shrink tumors to help get patients to surgery, or does it help improve outcomes even post-operatively? So we're looking at all of these systemic treatments for patients who cannot undergo a curative surgery.